Good afternoon, everybody. This is Dr. Al-Harbi. This is our fourth day of the International Symposium of Diabetic Foot Updates. I think we have Dr. Gustav. Dr. Gustav, are you available?
Yes, I'm here. Yes, I'm here. Thank you.
Oh, how are you?
Yeah, I'm fine. Thank you very much.
Nice to meet you. I sent you an email this morning, but I think you didn't catch it, did you?
Oh, yeah, perhaps I missed it. I'm sorry if I did.
That's
so.
Okay. I just need your confirmation. Anyhow, welcome to our meeting in Saudi Arabia. We spent the last 3 days with well-known international figures like you. And of course, you are welcome to join us for today. Just give me 1 minute to provide some briefing about you for our audience. So how is Sweden? Is it cold during this winter time?
Well, at least colder than Saudi Arabia, I guess. You had a little snow at least.
We have to visit Sweden one day at you know, the either the Christmas or the end of the year, or you know, to see how his life is there.
Yeah.
Just give me 1 minute. I welcome really Dr. Gustav Jarl from Sweden. He is an associate professor in 2019 in Örebro University. He has his PhD in 2014 in Örebro University. He had MCS prosthetic and orthotics 2003 from Johns Hopkins University. And he had MCS decision risk and policy analysis in 2020. This is impressive, really. University of Yale. Is that right?
Yeah, that's right.
Yeah, and prosthetics and orthotics, BSc and prosthetics and orthotics in 2001 from Johns Hopkins University. Thank you very much, Doctor. I'm really happy that you are joining us today. Please proceed for your first lecture. Thank you very much.
Thank you very much for your very kind invitation and presentation. I will try to share screen so you can see my. Oh, you need to enable.
Oh, yes. Okay, you are the host now.
Yeah. Okay. Thank you very much. Okay, I will try to get right. Okay, I hope you can see my slides now.
Yes.
Yes, okay, that's great. So this presentation will be about the IWGDF guidelines for the offloading of foot ulcers. So I will follow these guidelines very well. I will follow them simply. So these are not mainly my own thoughts, but rather they are based on the work of this working group, which is I am a part of this. So I'm very grateful for being invited to this symposium, and that is of course one of the one of the advantages with the pandemic, that we actually have started meeting online and meet each other over the seas and across the countries to a much larger extent. So nice to be here. The International Working Group on the Diabetic Foot is an international working group, obviously, and it was established about 25 years ago. And its basic approach is that every 4th year they produce systematic reviews of the literature. These are updated every time, every 4th year, and presented at this international symposium of the diabetic foot in The Hague in the Netherlands. And based on these systematic reviews, they also produce clinical guidelines. And these reviews and guidelines are in several areas of the management of diabetic foot. So it's one review and guideline regarding prevention of foot ulcers, another review and guideline regarding offloading, which I will present now, one about infection control and so on. So there are several, I think there's 6 or 7 different areas.
I think sorry, I think we are missing your slides. Can you?
Oh, you can't see them?
Yeah, we can't see them.
Oh, sorry. I will give it a new attempt. Okay. Can you see them now?
Oh, yes, go ahead.
Okay, sorry. Thank you for telling me. Okay, so if you're interested in this work, I think it's a very valuable resource, actually, because as a single clinician, it's very difficult to get an overview of all this research literature. So it's summarized very nicely in these literature reviews and these guidelines, and all are freely available at this webpage, iwgdfguidelines.org. So I would recommend you, if you're interested, it's a very good website. There you go. So this presentation will be based on one of these guidelines, namely the offloading guideline. So as you can see here, this is just this publication, which I was part of, and many other people who are very knowledgeable in this field. So this is just an overview. I know it's small to read, but I will walk you through it in steps. So this is a kind of flow chart for the overall guideline. So it starts with a person with diabetes, neuropathy, and a foot ulcer. That is the starting point, and then it splits to different parts, whether it's a non-plantar foot ulcer, a plantar forefoot or midfoot ulcer, which is the area where it's done the most research, actually, and also plantar heel ulcers. Unfortunately, there is very little research in that area, so the guidelines are a bit weak. There's not strong evidence for recommending anything. And this working group has the approach that we try to find the evidence available with this literature review, but when it's not available, we still try to make some kind of recommendation, but then it usually boils down to a recommendation based on clinical experience or expert opinion, so it's not that strong recommendation. And finally, there's also one section about when conservative treatment is not effective, when the ulcer actually fails to heal, no matter what you do in a conservative manner. And then it has some recommendations regarding surgical offloading, that is orthopedic interventions, when they're, for example, lengthening of the Achilles tendon and other things. So starting with this first one, the non-plantar foot ulcers. These can be located on several parts of the foot, of course. It could be on the dorsal surface, could be interdigital ulcers that between the toes, could be on the side of the toes, or can it be in the back of the heel. And this is one of those areas where there is not much research available. So it's mainly about making an individual solution to the single patient, to recognize where the pressures come from. If it's, for example, interdigital ulcers, or if it's on the side of the ulcers, it may be a problem related to too tight footwear, simply. If it's on the top of the, if it's on the back of the heel, it could be related to the footwear, but it could also be related to pressures when the person is lying in bed, as it is. Then a different offloading intervention is needed. This is this kind of back of the heel ulcers are pretty common when there's poor circulation in the feet and elderly patients, and they lie still either at home or sometimes when they're admitted to a hospital for some other health issue, they get these kind of pressure points that develop into pressure ulcers at the back of the heel. That is a problem where I work, and I suppose it's a problem elsewhere as well. And it is a shame that people actually get new ulcers when they're at the hospital, I think, but that happens from time to time. So you have to somehow relieve the pressures that cause the foot ulcers. This is one way to do it when it's back of the heel. This can be things to separate the toes. Sometimes you need to take other footwear simply to make room for the toes, especially if they are a bit deformed. So this is mostly an expert opinion advice, but it's highly individual depending on the particular patient's situation. Second, we have the plantar heel ulcers, and that is also an area where not much research is available. It is it's not extremely common, but it happens. And as you can see, it's typically here under the pressure point when you walk. And if you don't have sensation in your feet due to the neuropathy, people tend to keep walking on these kind of ulcers and keep them open. And there are different devices. What is recommended is these kind of knee-high devices. There are other devices as well. They do not all devices do not reduce pressures very effectively, but the advantage with using, for example, a cast is that it's non-removable, because as you probably know, many of these patients do not use devices as much as needed to heal the ulcer. So an advantage, although a cast does not very effectively reduce pressures, they may be more effective than other devices that can be removed. So when these kind of ulcers that are mainly neuropathic, when it's a pressure point, if it doesn't heal, you need to consider, is it because the device is not very effective, or is it because the patient is not using the device, or a combination thereof? Finally, this is a big slide. If it's a plantar forefoot or midfoot ulcer, this is the area where it's the most research is available. And there are several studies in this area. The problem is that sometimes, as you will see later, the strongest recommendation is for using a non-removable knee-high device. And there are two challenges with that. They are very effective, for example, a knee-high cast, but sometimes you don't want to close in the leg and the ulcer because there's severe infection and you want to keep an eye on the ulcer and the leg, or because there's ischemia and you're afraid of new ulcers developing. And finally, sometimes patients have gait and balance issues. So if you immobilize the ankle joint, they may have problems with walking. So these devices the non-removable knee-high devices are very effective when they are applicable, but sometimes they're contraindicated or cannot be tolerated by the patients. Then you have to move down to other devices that are interfering less with daily life and where they can inspect the ulcer, but they may be less effective for healing. So I will show you this hierarchy. Sorry, I should mention this as well. So when there's severe infection or ischemia, of course you need to focus on that in the first place, but you should still not forget about offloading, even if you need pretty urgent surgery because of vascular disease or you need intravenous antibiotics. You still need offloading. It's still not a good idea to walk on the ulcer. So you should not forget about offloading, even if other interventions are more urgent. Then I should show you this hierarchy of different devices. So when applicable, the first choice, which has shown the best effectiveness in studies, is the non-removable knee-high devices. These are typical two kinds of devices: the total contact cast and knee-high walkers that are made non-removable. For example, some have used a plaster, a bandage to make it non-removable, or using some plastic strip, just to make it non-removable, so the patient keeps the device on 24/7, like a cast. And then these interventions have shown the highest effectiveness for plantar forefoot ulcers. But as I said, there can be reasons why we do not want to do that, either because if infection and ischemia prevent it, or because a patient cannot tolerate it, because perhaps they cannot walk with a device when immobilizing the ankle joints, or if some people get some kind of claustrophobic sensation when being enclosed into this cast and they cannot remove it and such things. But often it's related to daily activities. Many of these patients have a poor gait and balance from the beginning due to the neuropathy and their health condition. And when you also put these kind of devices and immobilizing the ankle joint, gait and balance will be even worse. The second choice device is the removable knee-high devices. Here it's a walker, but it could also be a cast that is split open, a so-called biwalled cast that you put Velcros on. That will be also a removable knee-high device. This is effective for offloading, reducing the mechanical pressures on the ulcer, but it can be removed. So it's very important to discuss with the patient that it's very important to keep this device on all the time when he or she walks or stands. And that is sometimes a challenge. Many patients need to go to the bathroom at night, for example, and then it's quite cumbersome to put on this kind of device in the middle of the night. And if the patient cannot tolerate this either, the third choice is some kind of ankle high device. This is just one example. There are other devices as well. For example, the forefoot offloading shoe. There are also some kind of ankle high walkers that looks somewhat similar to this one, but just stops there and there. Some of these devices, in most cases, reduce the pressures on the ulcer less than knee-high devices, but some of them can be difficult to walk with. This one is, for example, can be very difficult if you have a poor balance from the beginning. And finally, if the patient cannot use any, or rather if no of these devices are available, the fourth choice would be some use of felted foam in combination with good footwear. And so this is kind of the last choice in treatment of this kind of ulcers. So this is the main recommendations, as I said, by this working group. And also this is the most evidence-based recommendation. Most of the research has been on this kind of uninfected and not ischemic forefoot ulcers. And it's been quite a strong evidence for using this highest category of devices in several studies. The other devices are less studied, so there's less evidence here, but they seem to have a weaker effect on healing. Finally, there are cases when you go on for several months or even years and trying to heal an ulcer. And as I said, it could have different reasons. One may be that the device that you have prescribed is not very effective, or that the patient does not use the device when walking. And at some point in time, you have to consider perhaps it's time to give up. You can't go on forever, because going with an open ulcer is a bad thing for several reasons. First, of course, it will be interfering with the daily life of the patient. He or she needs to go to the nurse perhaps 2 or 3 times a week to dress the ulcer. They may have pain sometimes, and an open wound, of course, is an entrance for bacteria, so you may get infections, sometimes severe infections. So it's not a small thing going around with an open ulcer for months or years. So it may be better to take a decision that, okay, now we tried for so long time, so it's time to move on and do something else. So there are some evidence for using some kind of different interventions to relieve pressure on the ulcer and promote healing. Digital ulcers, that are typical ulcers are when there are clawed toes, so you have pressure points on the tip of the toes, and there are flexor tenotomies that are very non-invasive. They are just, you have just perhaps a needle or a small scalpel and cut off the flexor tendon to straighten out the toes. And then you can have a pretty fast healing. There are several studies on that, of the toe ulcers, and also we prevent new ulcer because when you straighten out the toes, you will have more normalized pressure on the right part of the toe, not on the tip of the, not on the apex of the toe anymore. Metatarsal head ulcers, then there are different surgical options. You could consider Achilles tendon lengthening or metatarsal head resections or other joint arthroplasties to reduce the pressures on the metatarsal head ulcers. But of course, you should consider sometimes if you remove one metatarsal head, there will be higher pressure on the next metatarsal head, and we have a secondary ulcer. That happens from time to time as well. So why do these knee-high devices work? It's important to understand that there are at least 3 possible reasons. As I said, they are effective in reducing plantar pressures, high adherence when they're non-removable, and some people claim that they also may be effective because it's difficult to walk with the patient will walk less. So looking at them at a time, one at a time, this is an overview provided by Buss in 2016. And this is the reduction of plantar pressures at the first metatarsal head. So as you can see, here are the knee-high devices, the total contact cast, the removable knee-high walker, and a removable cast. And as you can see, these are the devices that reduce the plantar pressures most effectively. So that is one reason why they are effective. The second point about adherence, here you see, again, comparing different devices, but now you can see the blue line are the, the percentage of ulcers healed in 12 weeks, and the green line indicates the number of mean average days of time to healing. So you want the blue to be high up because many ulcers are healed in a short time. The green should be low. So now you see that the removable cast is not very effective for healing, although it was effective for offloading in the last slide. It's not very effective for healing. And that is because these devices are non-removable and also knee-high. So it seemed to be the combination of reduction of plantar pressures and being non-removable that is high adherence to wearing the device that is important. The third aspect is, do we need this about making it difficult to walk to patients? That is a theory they have, and we made a review last year about that. And there are not many studies on that, and it was hard to find evidence. But is it necessary to make people walk less if they have an offloading device that is effective? Well, one study found actually that more daily steps were associated with worse healing, even if they used a good device. 3 studies did not find such an association, although they may have been underpowered. And in 2 studies, the association was not clear. It was not possible to disentangle whether the healing was associated with weight bearing or some other factors. For example, if they were not wearing their device and so such things. So we concluded there is a weak evidence for reducing daily activities, but the evidence is weak. So this may be a little effect as well, but the main things are probably reduction of plantar pressure with the device and adherence to wearing the device. So people who walk very much may need to cut down a bit, but many of these patients are rather inactive from the beginning. And I think we should not ask them to cut down activity because they need the daily activity for other parts of their health, both physical and mental health. So the challenge has been the implications of these guidelines. There have been some studies to what extent these devices are actually used in the US and Australia and Europe. And they've usually found that these knee-high non-removable devices are not used very much. And we made a survey of a couple of students that I supervised, did a survey in Sweden as well. And it was the same pattern, that people tend to prescribe those two devices are least recommended, like footwear, and seldom use the recommended devices. And there are several challenges in this context, both of course knowledge, and there may be local traditions of what devices that are used, and we need to educate clinicians about the evidence-based offloading. As I said, there may be challenges with patients accepting the treatment because it can interfere with their daily activities. In certain countries, there can be reimbursement issues, depending on what country you live in, of course. And finally, there's a need, some of these devices require clinical training. For example, if it's a cast need, you need a trained cast technician to apply the device. So there are challenges, and I hope that we make some progress in the future with devices that are less interfering for the patient, so more people can accept it. But meanwhile, we also need to work in this implementation of these guidelines to heal more ulcers before they are infected and result in an amputation in worst case. So that was my last slide. So I will stop sharing there. Would you like us to take questions now or save them for the discussion section later? Are you there?
Yes.
Yeah. Okay.
We can see slides.
Would you like us to take questions now or save them for the discussion session later? I'm not sure.
Well, yes, actually, the slides are quite interesting. That
yeah, I can mail them to you if you want to share them. That's fine. Yeah, I can mail them. That's fine.
To be honest, here in Saudi Arabia, we don't have that frequent podiatrist or prosthesis facility, although we have, but we do not have much expertise, despite in major cities we have. But any ideas that for remote areas that they don't have the extensive technique to approach the needed requirements? Any advices how to optimize these solutions?
Yes, of course you have to work with what you have at the locality, your center. That is a challenge. I agree with that, because much of these research studies are conducted in certain countries. For example, most of the studies are conducted in North America and Europe, and very few are conducted in Asia and Africa and South America. And that is a bit unfair, because most patients live in those continents. So it's not really reflecting the challenges that you may meet in other parts of the world. So, but as we said, if you cannot use these devices that are mostly recommended, you can move down this hierarchy and try to find something as good as possible, at least given the circumstances you work under. I understand that, of course, you have different things to consider, and as I say, different resources, if there are trained staff available and if you have equipment and so on. So I think we should move down when needed in this hierarchy, but try to keep as high up as possible, so to speak. But that is a challenge. There are interesting devices that are being developed, for example, in India, just because of these challenges with the equipment and trained staff. There's not much evidence yet, but I hope it will be improved. So we can see if there are devices that are easier to implement also in settings where we don't have all the resources we wish that we had.
Does this devices. Can we have the same idea after amputation, or only your focus is only on foot ulcers?
Yeah, this presentation is only about foot ulcers. Of course, it can be a problem with healing after the amputation as well. But this reviewing guideline only applies to foot ulcers. So we may need to think a different way if you have an ulcer after an amputation. Yeah.
But I remember I was working in a medical city in Riyadh some time ago, and we tried to utilize these devices exactly as you instructed. But one was, there was a challenge that once you do the cast, and sometimes we face some discomfort, or we are obligated to remove the cast, and we waste everything. So we go to the next step, as you mentioned. Is there any instructions to minimize the failure, or at least, I would say, unsuccessful utilization according to the hierarchy that you mentioned?
Yeah, as you said, there can be challenges with these casts because many of these patients do not have sensation, so there can be small damages to the skin or even ulcers without the patient noticing. So it's very important that a cast technician is properly trained, and you may need to replace the cast more frequently in the beginning just to make sure that there are no problems. But I agree. I agree. There are many challenges also with the patients accepting to be in a cast. That is challenging. I agree completely.
But do you think the fiberglass type of cast is good enough, or you prefer the gypsum one?
Oh, well, I'm not a cast technician. I know that also in Sweden, different cast technicians use different techniques, to be honest. I think the fiberglass cast is lighter in weight, and it also hardens in a shorter time, so the patient can walk on it after a shorter time period, because this traditional casting material needs to settle for, I think, like 24 hours before it really can bear weight on that. So I think there are certain advantages with the fiberglass cast, but you should be aware, of course, that the surface of the fiberglass cast can be quite sharp. So you need to be careful, and sometimes perhaps when the person is sleeping, they need to wear a sock on the other foot, so they will not get an ulcer on the other foot because they could come in contact with this sharp material of the fiberglass cast.
I see.
But I'm not a cast technician. So.
Yeah, that's okay. Any question from the audience, please?
No, it doesn't seem so.
Yeah, I think.
But I will send the slides to you afterwards in case you want to share it with the other. Yes, please do.
Yeah. So we'll move to the next lecture, please.
Yeah. Okay. Thank you very much. So now we will move on to the prevention of foot ulcers. That is before the ulcer happens. So I will try to share screens again. And just change my. Once again, I can share you the slides with you and be happy to share it with everyone. So,
thank you very much.
Yeah, so it's just good if it spreads. So this is, as I mentioned, footwear is usually not recommended to offload foot ulcers, but they are used and recommended to prevent foot ulcers. It is important to distinguish those two scenarios. All the same patients will, of course, both need prevention and treatment. So this is just the background that you probably know about, that these foot ulcers very often, they're quite frequent in this patient population. And although most ulcers healed, fortunately, the recurrence rate is very high. There's been an overview from 2017 by Armstrong and colleagues, when they found that in general in the publications, in studies, they found that about 40% recur within 1 year after healing. And after, I think, about 3 years, about 60% recurred. So there's a very high recurrence rate. And also most amputations are preceded by foot ulcers. So we really need to work on this prevention, not only make ulcers heal, but prevent them from happening in the first place. Therapeutic footwear is recommended to prevent foot ulcers, but unfortunately, inappropriate footwear can actually cause foot ulcers. To reduce the risk of new foot ulcers, we need to find the causes for the particular patient. So I tried to make a structure for this. Sorry, I think someone may have forgotten to mute their microphone. There's some background noise.
You can mute all from your side, please.
Aha, okay. Sorry.
Just squeeze left side button over the participants.
Okay, let's see if I find it. And the participants here. No, is it here? Oh, there it is. Oh, okay, okay. Thank you. Okay, so as you know, the etiology of foot ulcer is quite complicated. There are many different factors that interact and produce a foot ulcer. And that can be difficult to communicate with a patient. All these factors, you have neuropathy, angiopathy, you have infections that may develop, you have different external trauma, and that can be many different kinds, and so on. So this etiology is very complex. And you probably have seen in some publications these flow charts. You have arrows and boxes everywhere, and they try to explain this flow, how it results in a foot ulcer. So they are good, but they are not very useful for communicating with the patient because they are so complicated. So we use this very simple, very simplified etiological model of foot ulcers. You may even say it's simplistic, but it's useful for communicating with patients and also communicating with the clinicians who are not specialized in diabetic foot. And it simply divides these factors into two sets of factors. First, we have these predisposing risk factors, which are, as you know, peripheral neuropathy. The patient cannot feel pressure or pain. You have artery disease and foot deformities that increase plantar pressures and so on. And all these factors, they usually do not produce a foot ulcer in itself, but they increase the risk of developing a foot ulcer. Usually some external factors needed that trigger the development of a foot ulcer. And when I speak to my patients, I use these terms, or rather the Swedish equivalents of these terms. So this is the predisposing risk factors, that's a technical term, of fragile feet, to make the patient understand that their feet are very fragile. It just takes a little trauma, trivial trauma, to induce a new foot ulcer. But they need to understand that their feet will stay fragile for the rest of life. Even if the first ulcer heals, their feet can very easily develop new foot ulcer with just a small trauma. And then you have these interventions. Some of these interventions by the healthcare are aiming at the predisposing risk factors. This could include orthopedic surgery to correct foot deformities and thereby reduce plantar pressures. It could be vascular surgery to improve the blood circulation in the feet. It could be stop smoking, of course, also to improve the circulation. But here we have these interventions that are aiming at the precipitating risk factors. Let's see if I can. This intervention, here comes therapeutic footwear, orthosis, podiatry, and so on. And these are aiming at trying to protect the feet against this small trauma that trigger the foot ulcer. Most foot ulcers are either triggered by mechanical trauma or thermal trauma, that is very high or low temperatures in the environment. And a few occasions could be chemical trauma. For example, if people are using a callus removal plaster or product applied to the skin and they forget about it and it gives a chemical burn, that can happen. But in most cases, it's mechanical or thermal trauma. So I try to visualize these mechanical and thermal trauma that trigger the foot ulcer. So this is what the footwear and orthosis should protect the foot against. So you have the acute dorsal trauma, typically by dropping something heavy on the foot. You have tight fitting footwear that put pressure, typically on the toes. And you have acute trauma when they stumble into things with your foot. Could be on the sides of the foot as well. And you have the repetitive pressure and shear to the plantar surface when you're walking barefoot or in inappropriate footwear. Or you have acute plantar penetrating trauma when you step on something sharp. Then you have this movement and shear, typically from loose-fitting footwear that makes a blister and then an ulcer on the skin. Then you have also dangerously high and low temperatures in the environment. That is very dependent on where you live, of course. If you live in a cold or hot climate zone, and you can have a burn or a frostbite. If you don't have sensation in your feet and you walk on a hot surface, you may not notice it until you already have an ulcer. In a similar manner, if you have an inappropriate footwear in a cold country, like my own, you can have frostbites without noticing if you don't have sensation and pain in your feet. So how do footwear protect against these factors? Well, when it comes to dropping things and bumping into things, you want a footwear that covers the foot. This is, of course, a challenge in hot country zones. And I think we need to develop more footwear or material that is breathing in more cold, because using traditional covered footwear in a hot climate zone is very challenging, of course. It will be very hot. But for many of these patients, you will need actually covered footwear to protect against this kind of acute trauma to the foot. Where I live, of course, this is not a big problem, making people wear covered footwear, at least not in the winter because it's so cold outside. But still, my patients walk barefoot inside and kick their foot into something or drop something on it and develop foot ulcers by that reason. Then you have the plantar foot ulcers. They can come either from these repetitive pressures and shear. And then you need something that redistribute the pressures under the plantar's foot surface. That it could be shoe insoles, could be rocky bottom shoes that reduce pressures on the forefoot, and a low heel height, of course, because a high-heeled shoe would increase the pressures on the forefoot. Then you also need a sole on the footwear that actually protects against things that can penetrate the foot sole. So it should not be too thin and soft. Finally, as I said, inappropriate footwear can actually cause foot ulcers instead of protecting against foot ulcers. So you should avoid footwear that is tight fitting, so it will cause pressure ulcers, but neither be so loose fitting that it's actually sliding up and down and causing blisters and also in that way. So it's important to have enough space for the foot, of course, but it should also in the same time have a firm fit, so it cannot slide back and forth. Again, if a person had a healthy foot, you would notice in time if you have pressure points and shear. But if you cannot feel these blisters developing, you will not remove the footwear in time, and you will have foot ulcers instead. Finally, as I said, you have these high and low temperatures. Could be walking barefoot on a hot beach, or walking with too thin footwear in a cold climate zone. It could be also other heat sources. For example, if you're riding a motorbike and put your foot against a hot part of the motor, or being in a workshop and having hot equipment that it touches the foot without you not noticing, when you cannot feel pain. So the footwear should protect against excessive heat and excessive cold in the external environment. So I think we need it for each patient to think, why is this patient's feet fragile? What do you have, the angiopathy or neuropathy or foot deformities? And do they understand that their feet are fragile and would need protection? That this everyday trauma that is quite trivial can actually start a new foot ulcer. Then we should consider what kind of triggers are applicable for this patient. Not all patients go to the beach in a hot summer day. but some do. And not all patients walk barefoot at home, but some do. So we need to find what is the threat to this foot for this particular patient. So the problem I see in my own country, at least sometimes, is that we prescribe the same type of footwear to all people, no matter what the problem is. And that is not a very good strategy. So I will just give a few examples of what can happen then. This is just fictive patient cases, but they are typical to what you see in a clinic. This patient would be a person with a previous metatarsal head ulcer. This is typically caused by repetitive pressures in combination with sensory neuropathy. They cannot feel this high pressure, repetitive pressure. And finally, there's an inflammation under the skin and the foot ulcer develops. So in this case, we need to reduce the plantar pressures. We need to convince the patient to wear footwear indoors. We need to, if the person is working and need to walk a lot at work, it's important that we get some kind of footwear at work that can be accepted. It could be the rocker bottom soles to reduce the plantar pressures and shoe insoles. And thereby it may be possible to prevent these kind of repetitively formed ulcers under the forefoot. In contrast, if you have a patient with an ulcer who had developed an ulcer in the same location, but not because it pressure points, but actually from a burn walking at the beach in the summer on some other hot surface, you would not need the same intervention. That you would need something that protect against burns. You perhaps need to talk to the patient, being careful with walking barefoot on hot surfaces, or perhaps that never walk barefoot in that kind of context where you can get burns, that I always have some kind of footwear, at least with a sole, even at the beach, and if you're going to the ocean, you always need to do it. So even if it seems like a similar ulcer, you need a different intervention to prevent new foot ulcers. Thirdly, patient with a previous ulcer at the tip of the toe. These are typically not much due to neuropathy, but rather angiopathy. This person has no pressure points on the plantar surface, but it's important, the trivial trauma here will not be burns or repetitive pressures, but rather that this person has too tight footwear that presses on the top of the toe. And this in combination with this angiopathy triggers new foot ulcers. So in this case, we would not even insoles, because we do not need to redistribute pressures. We don't need rocker sole, but we need a properly fitting footwear that do not produce pressure points. I'm trying to find some compromise that a patient can accept, both from a functional perspective, but also from an aesthetic point of view, if they want to use the footwear on social occasions. So there are three different approaches that I think we should have a kind of personalized approach. You know, this trend with personalized medicine. This is the equivalent in diabetic foot. So these three patients, if you had done what is at least some clinicians in my country do, prescribe the same type of footwear to all of them, the first patient would not use them indoors because they're too heavy with this rocker sole. And the second would not use them at the beach and perhaps get a new because they're too hot to wear on the beach. And the third one will not be used at social occasions, but because traditional therapeutic footwear is too ugly. And when adherence is so low, they will develop new foot ulcers. So I think we should remember that the aim of prescribing footwear is not to prescribe footwear, but to prevent foot ulcers. And then we need this more personalized approach where we can identify what is the trigger for this patient, what do we need to protect this patient's feet against, and then we can design the intervention and stop this from happening. So I think that was my last slide. I will stop sharing. And then footwear is both simple and complicated. It's not a very technical solution intervention, but it's so much about traditions and cultures and even religion and aesthetics, and so it can be very difficult to. It's very important to get into the dialogue with patients. Because if they don't agree with what I prescribe, they will never wear it and it will be completely useless. So it's a simple intervention, but it can be complicated to prescribe.
Do you think that patients with the neuropathy have the same chance as with people who has nothing?
It's the same chance to develop foot ulcers?
Yes.
Yeah, I think they have much higher risk because they usually cannot feel these warning signs. That if you have a healthy foot, of course, you will notice if you have too tight footwear or if you have a small blister developing. And you have this kind of warning sign. The pain is the warning sign that something is wrong. But when you don't have that warning sign, it's so easy to develop new ulcers. So that is quite a big challenge.
And you think those people with who get a previous incidents of injury and they ignore themselves, then they get healed. Do you think that they will have the same chance for people that who never have any trauma before or any injury to the foot?
Yeah, they have seen that probably the strongest risk factors for developing a foot ulcer is that you have had one before. So that is a strong risk factor, and I think that is very important to communicate with the patients, because sometimes they feel that, oh, it's healed, then it's all over. I think you probably met that opinion in patients, and it's perhaps sad to say to patients when it's healed, but I try to communicate that your feet will always be fragile and you really need to be careful with them. Otherwise, you will be back here in 2 months with another ulcer. So I don't want to make them depressed, but I want them to be realistic that you really need to take care of yourself. Your health, your skin is healed, but your feet are not healthy.
But the other people, as you know, sometimes we have two types of people who are still in the early stage, so you can do these precaution measures. But people that who they don't have ulcers, they don't have amputation, they don't have injury, but they have multiple soft tissue infections, and they have a swollen foot and leg. Do you think the same thing can be applied to them and they will have the same results?
Oh, well, it probably depends on how these infections started, or if it started with a crack in the skin. I don't say that footwear helps against everything, of course not, but you probably need to identify how it started. It can start with things that are not related to footwear. Perhaps people cut their nails too short or get other things that makes perhaps a small ulcer and infection starting. And so you need to somehow identify what made the ulcer start so we can prevent that from happening again. And sometimes footwear is the solution and sometimes it's not.
Well, thank you very much. I think we have some of the audience, they ask for your presentation slides.
Yes.
So you can, you send it to the chat or send it to me by email, then I'll distribute it to them.
Yeah, I will send them, return them in the same email so you can distribute to people who are interested. I'm happy to do that. Thank you.
Thank you very much, Dr. Gustav. You know, you are the chairman for this meeting.
Yeah.
I should have some rest.
Okay. Then
but I think that the next speaker, Mr. Chairman, is he's our friend from Romania, Dr. Florin. But I think yes, Dr. Dan is taking his place. Dr. Florin hasn't. I think he have COVID-19.
Unfortunately, Dr. Florin Borica, yes, has the infection with COVID-19. Hopefully, he will recover fastly. And instead of him, I will present the management of the diabetic foot surgical pathology. And I will present you our cases from Romania. And hopefully, you will enjoy it. And after the presentation, if you have any questions, I will gladly answer to you.
Which part of Romania? Transylvania?
Not
Or
that
Bucharest?
part, the southern, the Bucharest, yes, the southern part of Romania. And
Yes.
we are working in a large center with diabetic food, and we like this pathology.
Yes,
That's,
if you allow me, I'll just give a little brief about Dr. Florent.
of course,
Dr. Florent Tudor Koberka, he is a consultant general in laparoscopic surgery in Romania, Bucharest. He's a lecturer in the Department of Surgery, Carol Davila, University of Medicine and Pharmacy, Bucharest, Romania. Thank you very much, Doctor, speaking on his behalf, and thank you very much joining us for this important event. You can proceed. Thank you very much.
Thank you. I will share my screen just in a moment. Okay. Okay.
You are
now
the
I'm
host.
the host. Yes. Thank you. Thank you. So I will share this now. Hopefully, yes. Now, so I will present you the management of the diabetic foot surgical pathology. First of all, I will present you some important public health issue data about the diabetes. So we can say that every 22 seconds, someone is diagnosed with diabetes, and that's very, very advanced and important health issue that we will discuss about it. We have to look at this pathology as it is for the all systems of a patient, and every 19 minutes, one diabetic patient loses his sight and another one develops end-stage renal disease. So the diabetes has a lot of complication, as I said, for all the systems. And every 19 minutes, there is performed a pelvic limb amputation. Now we're talking about above knee amputation and below knee amputation. And unfortunately, every 10 minutes, a person dies because of diabetic complications. In Romania, we have a number of 1.2 millions of patients with diabetes. And from this number, 250,000 patients present diabetic foot, a very bad complication of this disease. And over 70% of these major amputations are performed for the diabetic patients. And the large amputation, that means above knee amputation and under knee amputation, represent 22% of surgical procedure for diabetic foot. So as a definition, we have to say that any pathology of the foot resulting from the presence of diabetes or its long-term complications represent the diabetic foot. And this pathology is the consequence during the course of the disease, which means examples like infections, ulcers, like previous doctor presented the ulcers of the diabetic foot, and different soft tissue disorders associated either with neurological complication and different degrees of peripheral vascular damage. Because as we will see later, we have to differentiate the patients with diabetic foot, which one has the predominance of the neurological affection and which one has the peripheral vascular damage. Now you have here some photos with different infections and abscess of the diabetic foot. And now I will show you a short scheme about the diabetic infection and diabetic gangrene that can occur at these patients. So we have on one side the neuropathy, and on the different side the ischemia. That means the peripheral vascular disease. So these two can occur and result in narrow ischemia, plus the germs that can be at that site and provoke the infection. So it can result in diabetic gangrene. So the pathophysiology, from this point of view, we are talking about a combination of factors. We have the diabetic neuropathy, the peripheral arterial disease, the anomalies in the biomechanics of the foot, because I will present that in the diabetic foot, the skeleton of the foot has some damages, so we will have some difference beside the biomechanics of a normal foot. And we also have some lesions with a slow evolution that can evolve to the infection. First, the diabetic neuropathy is the most common and earliest chronic complication of the diabetes. So we will see more cases of diabetic neuropathy than the peripheral vascular disease. The determining factor of the neuropathy is the persistent hyperglycemia. So a patient who does not have a good control of the diabetes and has the persistent hyperglycemia, that will produce in the first steps some changes from the electrophysiological and then histological changes of the nerve. Then this will become the nerve damage that has clinical expression. So unfortunately, the diagnosis of diabetic neuropathy is most often made late, when already has appeared an ulcer or the absence of the pain. So that means an advanced degree of neuropathy. The modified biomechanics that I told you about, they are presented as weight support abnormalities. The leg deformities, as you can see in this picture, we are talking about hammer toe and claw toe, and the protrusion of metatarsal head. Also, we have cases of Charcot foot. The Charcot foot is practically change of the entire skeleton of the foot when all the bones are presenting inflammation and the foot has a very big volume compared to a normal foot. So here we have the differentiation between the hammer toe and the claw toe, and also the differentiation between the head of the metatarsal. So in the claw toe, you have a preeminent metatarsal head compared to the hammer toe where it's normal. So here we have also on the radiography and another example of hammer toe. And this is the Charcot osteoarthropathy. That is practically a complication of the diabetic neuropathy, where we can see the entire skeleton of the foot and all the bones that have great inflammation and a large volume of the foot that is observable from the first moment. Also, the bones present a very low density, as you can see on the X-ray. And the treatment for this kind of the disease is a total repose, and the patient has to immobilize his foot so that the inflammation can decrease. Now, the other aspect that I was telling you about is the peripheral arterial disease. So it has a 30 times higher prevalence at the patients with diabetes compared to normal patients. And the problem with the arterial wall is that it becomes very stiff, like a lead pipe, as we know from the books. We also have to talk about some particular pathology. It's called mediocalcosis, which represents the deposit of calcium in the muscular middle layer of the arterial wall. And as it has been studied, the histopathology means that there are two important modifications. One is the thickening of the vascular basement membrane, and the second one is the endothelial proliferation. So here's an example of how it looks, the diabetic foot of a patient who has the predominance of arterial disease, not the neuropathy. So you can see the lack of pilosity. You can see the inflammation that starts from the toes and goes up to the ankle. And also the necrosis that has occurred in the left picture. Here are some other examples of peripheral arterial disease in the diabetic patients. And another one, the gangrene of the toe. So this one, as you can see, goes up on the foot close to the ankle. Now, when we are talking about infection and the diabetic gangrene, we are talking about a polymorph flora. So we have two categories: gram-positive bacteria that are aerobic, like Staphylococcus aureus or Staphylococcus epidermidis. We have gram-negative bacteria that are aerobic, like Escherichia coli or Klebsiella or Enterobacter. And we have anaerobic bacteria. Usually in our center, we have antibiotics prescribed by the culture that we had in the wound at the first moment when we have the patient. And after the culture, after the result of the culture, if we have the good antibiotic, and know if we don't have something that is sensible for the bacteria, we have ertapenem, which is a good treatment for any bacteria that is found. The risk factor for the diabetic foot. We have here a list with these criteria. We have the male gender. We have the patients that have diabetes with an evolution of over 10 years. So it's a long history of the diabetes for that patient. We have the peripheral neuropathy, the modified biomechanics, the vascular disease, as we said, the peripheral arterial disease, the smoking, which is practically a factor also for the arterial disease, the ulceration and the amputation that also have been in the medical history of the patient, and the poor control for the blood sugar, which I've said, it means that a poor control of the diabetes. The clinical examination of the patient with diabetic foot. First of all, we have to see the point of view from the vascular evaluation. So we have the palpation of the peripheral pulse. We have to observe the color changes of the teguments and of the skin. If there is any edema, the presence of edema, the variation of temperature, that also the patients with vascular disease, they have a very cold skin of the leg. The changes of the skin that can occur, like the atrophy, the absence of pilosity or onychodystrophy, and also the modified venous refilling time. The next point of view is the neurological evaluation. So we have to search for the perception of vibration and the pressure. We have to find the verge of tactile sensitivity, the pain sensitivity, the perception of temperature, and the tendon reflexes that have the patient, and also the test, the Babinski test and the Romberg test. Investigation. Now, from the investigation, we have the first investigation that we made in the laboratory, the blood sugar level, the glycated hemoglobin, which shows the control of the diabetes and how good is the control that the patient kept in the last 3 months, the hemogram or complete blood count, the urine tests, the blood culture, and the bacterial wound culture that I've said before that we have to do when the patient is admitted in the hospital and we recognize the infection. Also, we have imagistic investigations like radiography, where we can find the different changes that can occur, like osteomyelitis, fracture, dislocation, osteolysis, because the infection will produce the osteolysis of the bone. The calcium deposit in the arterial wall, like I said before, the mediocalcosis, the calcium deposit in the muscular layer, and the gas accumulation in the tissue that also represent practically the evidence for infection. So we have here some example of radiography, like low density of the bones. Here, the articulation is not longer viable here also. And here that a patient that has transmetatarsal resection. Also, the vascular evaluation is a very important point of a patient with diabetic foot. So first of all, we'll talk about the non-invasive evaluation, like Doppler vascular ultrasonography and ankle brachial index. These are two important investigations because they are very easy to do. They take a short time, and they can decide also which level of amputation we can do. So we will say that that patient has the good chance to recover from the surgery, and the wound will have good chances to heal. And also, we can mention the blood pressure of the toes, the measure of CO2 transcutaneous, and laser Doppler velocimetry. See, here we have the ankle brachial index that, as I said, is an important investigation that can see the difference between the blood pressure that we have at the arm and at the ankle. So here we have on the measurement of the blood pressure on the arms and on the lower, the tibial and the pedis dorsalis artery. And we have the interpretation of the ankle brachial index here that can show whether a patient has a normal value or he has a grade of obstruction of the vessels. So we have between 0.9 and 1.3 a normal ankle brachial index. So that patient doesn't have a peripheral vascular disease. We have the small obstruction between the 0.7 and 0.9. And under this value, we have moderate and severe obstruction of the artery. So it's clear that that patient has an advanced peripheral disease, vascular disease, and so that will be the chance for a high amputation. So after the non-invasive evaluation of the patient, we have also the evaluation with invasive methods. Here we have the arteriography, the CT angiography, and the MR angiography. As you can see here, the example of the limb. Yes. Also here is a gangrene of an arterial patient that has an advanced vascular disease. And this is what it looks like an ischemic lesion. You have here a dry gangrene, a dry necrosis. So this patient has the advanced vascular disease, and fortunately, it isn't become here an infection. So it hasn't, it doesn't have any secretion here. So we can do the surgery, and he doesn't have the germs, and he doesn't have a culture that we'll have here. Here we have the ischemia of the toe with a lot of secretion, and also this is a necrosis of the toe. So this has also ischemic lesion. This kind of patient, it's clearly that he doesn't have a pulse in the peripheral. So this is a candidate for the underknee amputation. It's clear for everyone that the vascular disease has an advanced stage for this patient. Here is also an example of abscess and phlegmon of the foot that the surgical treatment for this kind of patient has to be a large incision, because we have to see how deep is this abscess, and we have to evacuate all the necrotic tissue, so we can go until we see clearly visible healthy tissue, so it won't present a risk of reinfection. This is the picture of neuropathic lesions and the superficial and deep ulcers, like we've seen before, the Dr. Gustav Jarl. And this is a superficial ulcer of the toe. This kind of lesion, because of an advanced neuropathy, the patient doesn't even know that he has this kind of ulcer, and some of them stay with the leg close to some hot objects, and they fall asleep. Usually they wake up in the morning, they have some very, very big and nasty lesions that they don't know about, they didn't feel them. And this is an ulcer of pressure. So the treatment for this kind has to be also the orthopedic shoes and the surgical intervention and the prevention of infection. Here we have an example of extensive separation of a patient that you can see the infection starts from the toes and goes up close to the knee. This is the Charcot foot that I told you about. This is the entire inflammation of the skeleton of the foot that can occur. So in the left image, we can see that this patient had the resection, the transmetatarsal resection of 2 toes. And after that, he developed this Charcot foot. So he has also need to immobilize the foot so that the inflammation can decrease. And also is the same treatment for the patient in the right picture. Now, the diabetic foot treatment has to be seen like multimodal and multidisciplinary treatment. In our center, we have over 1,000 surgical interventions per year for diabetic foot pathology, and we have to cooperate between the general surgeon, the vascular surgeon, the plastic surgeon, and the diabetes. So we can have an entire control of the infection of the foot, the diabetic foot, and also a good control of the diabetes. So first of all, we have to talk about prevention. We have to identify the high-risk patients. Now, from the point of view of education of the patient, we have to talk about the careful choice of footwear, the orthopedic footwear, the daily inspection of the foot. So especially for those patients, we have predominance of neuropathy because they cannot feel very well what's happening with their foot. We are talking about a daily good foot hygiene and hydration. We have to talk about the avoidance of self-treatment of foot abnormalities and high-risk behaviors like barefoot walking. Also, a great care for the neuropath patients. In case of any modification appear, like red skin or a strange smell that appears at the foot, the patient has to come to the hospital to have a prompt consultation. And also the orthopedic shoes and devices that are indicated for this kind of pathology, the treatment of callus, and also a good nail care so they can prevent the infection of the tissues. From the identification of high-risk patients, we have to see, especially those that have a medical history with previous amputation, ulcer of the leg, and those that present a peripheral arterial disease with an advanced degree of peripheral arterial disease that can complicate from the infection of the toe to a large amputation like under knee amputation or below knee amputation. We also have to take a good examination and the lack of sensitivity, the leg deformation, the absence of the pulse, the prolonged venous refilling time, and the low anchor brachial index that can identify an advanced peripheral arterial disease, and also the lesions that look like pre-ulcers, pathology of the skin. The treatment has to be multimodal. We have to search for methods of redistribution of foot plantar pressure. From the surgical point of view, we have to remove all the necrotic tissue, including microthrombosis or any necrotic tissue that can go to a risk of reinfection. We have to take care of special bandages, the antibiotics that are chosen, as I said, from the wound culture, what is sensible in the wound culture, and also the revascularization techniques that are for the vascular surgery. And we are talking also about the amputation for the deep lesions with sepsis, with the gangrene, and the failure to restore foot functionality. There's also a part of the treatment which represent the local treatment of the lesions, like different bandage and dressings that are addressed for the patients with advanced vascular disease. These examples of the bandages and dressings are like transparent film dressings, those that have hydrogel, hydrocolloids, alginate, that can help the wound to recover faster, and those that lower the risk of reinfection. As I said, we are talking about these special bandages, especially for those patients that have the predominance of arterial, the peripheral vascular disease. Also, the local substances like physiological serum, the antiseptic substances, and local antibiotics like bacitracin or neomycin. After the surgery, we can talk about the complementary methods to treat a diabetic foot. So here we have some examples like hyperbaric oxygen therapy, the negative pressure wound therapy. So the negative pressure wound therapy will help the granulation tissue to grow faster and the wound to heal in a shorter period of time. And we also talk about the plastic surgery and vascular surgery. Here's an example of negative pressure wound therapy that is for this patient who has an ulcer. And here is an example of the plastic surgery. We have here the first moment of surgery, and then here is the plasty that was performed in the plastic surgery section. And here, 3 months after that, the recovery of the patient, which has the look of the leg is close to normal. The negative pressure wound therapy here, as you can see here, is mounted the negative pressure wound therapy, and after that the wound that healed in a very good way in fast time. We're here talking about a wound that has recovered in about 3 or 4 weeks. So for this kind of lesion, it's a pretty good result. We have here the vascular surgery for a patient with arterial disease, and here in the first moment when she had the surgery, we're talking about the transmetatarsal resection that eliminate the infection from the leg, and after that the vascular intervention, which was a bypass. And here we have the result, how the wound healed, and also we have the difference between anchor brachial index from 0.4, so that means 0.4, which is a severe obstruction, to 0.8, which is a very small obstruction. So this patient recovered very well from multimodal treatment. First, the transmetatarsal resection that was performed in our clinic with general surgery, and after that going to the vascular surgery to perform the bypass, and then recover very well, and the wound which was healing also well. So in conclusion, we have to see that the surgical indication for the diabetic foot varies depending on a number of factors like age, like the presence and type and number of associated cardiovascular disease, and the association of diabetes complication. We are talking about nephropathy and retinopathy. And also an important thing that we have to mention is that the presence of sepsis and anemia, because we are talking about a diabetic patient, we have a systemic disease that can affect all the systems of the patient. And from the surgical point of view, we have to see whether we have a patient with the predominance of arteriopathy or whether we have the predominance of neuropathy. A thing that we have to mention also is the predominance of arteriopathy and the lack of possibility of revascularization. It's very often the evolution to go to a major amputation, the below knee amputation or the above knee amputation, while the predominance of neuropathy and having a vascular substrate, which is very necessary for healing the wound, is often associated with a febrile outcome, and very often we have patients with this neuropathy that can limit the resection to the transmetatarsal resection and not going up to perform a major amputation. Also, we are talking for the diabetic foot lesions for a patient which has at least 5 years from the beginning of the diabetes. And as I said before, it's a long-term complication, and it has been associated with male, with smoking patients and alcohol-related behaviors, which are present, unfortunately, in a higher proportion in our country. And the appearance of the lesions varies greatly with the degree of the control of the diabetes. So many patients we have that have the poor control, they are under the treatment with oral antidiabetics instead of insulin, because when they have only oral therapy, they cannot control very well the blood sugar as they have with the insulin. So these patients are often more candidates for the diabetic foot pathology than those with insulin. And also we have to mention that the sepsis associated with these kind of lesions represent a severity factor, which in some cases might provide a surgical indication for major amputation. The presence of nephropathy, anemia, and cardiovascular disease, they are almost always the expression of low general biological status of the diabetic patient. And that's why we have to manage these patients in a multidisciplinary team. And the presence of surgical interventions for the diabetic foot in the medical history denotes also the stage of the control of the diabetic disease. So there are many patients that have a big number of interventions, 3 or 4 interventions, that can be seen as a not a compliant patient to the diabetic treatment, and also an uncareful treatment of the wounds that can present the risk of reinfection and then a major amputation. Thank you very much.
Thank you very much. It was a very nice overview of both the challenges and the potential treatments for the diabetic foot. I have a question. You mentioned several times, I emphasize this, the importance of multidisciplinary treatment, and I completely
Yes.
agree with that. What is the structure of care in your country? I understand you work in a big center where you have a lot of patients under treatment. Do you have this kind of teams at the bigger hospitals that the primary care can refer to?
Well, we have in our clinic, we have the general surgery, which is the main department that takes care of this kind of patients. And we also have a vascular surgeon that can perform the bypass for the arteriopathic patients. Unfortunately, we don't have any plastic surgery in the hospital, but we have colleagues in a different hospital that we can send the patients to perform that kind of plastic that you have seen in the pictures. And also very important, we have a department of diabetes and metabolic disease in our clinic, in our hospital, because usually when this kind of patient come to us, they come with sepsis and a large number of leukocytes. We perform the surgery, and then many times we have to transfer these patients to the diabetic department for the entire metabolic recalibration. And some of them, as I said, they have nephropathy, they also go to dialysis, they also have the metabolic complication, then they need to readjust the treatment for the diabetes. And that thing that I said, the poor control, the previous poor control of the diabetes, that was the patient with oral anti-diabetic pills, and then the switch that they have to do to go to the insulin treatment, often they are making this switch after they come to an intervention at us. So we have to admit into a hospital a patient that has a gangrene, that has a big infection of the diabetic foot. We perform the surgery, and then the patient is transferred to diabetes, so he can be recalibrated metabolically and had the new adjustment for the treatment, so he can have a long-term success.
Yeah. Yeah, that's important to get the whole picture of this multi-comorbidity. I completely
yes,
agree.
because it is a systemic disease, and many of these patients cannot realize the importance of the control of the diabetes, because from here they have the multitude of associated pathologies. Like I said, the arteriopathy, and this entire vicious circle, because you have the infection of the foot that causes the hyperglycemia. The hyperglycemia cannot solve the wound, and you can administrate the antibiotics, you can perform the surgery, but if he doesn't have a good control of the diabetes, the wound won't heal. So it presents the risk of reinfection, and then you perform another surgery, another risk for them.
Yeah. Yeah, it's a complicated, both the condition and the treatment. Thank you very much. I don't know, did the other chairperson, Janet Travis, have anything to add?
Thank you.
You're also the next speaker, so you may want to.
If you allow me just a small
sorry.
question.
Yeah.
Yes.
Sorry,
Dr. Dan, what about VAC machine? How confident do you think, the VAC machine, the major drawback or the major disadvantage is that you have to replace the costly colostrum every time, which sometimes is not possible to replace due to financial issues. The second question, as you know, the hyperbaric oxygen is still under debate. Is it useful or not useful? Which patient will get benefit from hyperbaric oxygen? So what is your experience in that?
Well, unfortunately, with hyperbaric experience, our experience with hyperbaric treatment is not a very good one. Actually, we use that at a patient which is between where we have to decide if he will have another intervention or we can use the hyperbaric oxygen therapy. Usually they go to another intervention, because this is the time It's a critical period of time that we use between the first intervention and we have a wound. It will heal or it will not heal. And from my point of view, as a surgeon, I always consider that a good intervention is the most important thing in this treatment, and the antibiotic that you choose for that patient, and the clean bandage that you have to do every day. Also, we have the vac machine that you said, and the negative pressure. The negative pressure wound therapy that we use some kind of patients, especially the arteriopathic patients. But also, it is a small borderline for those who work this kind of wound therapy and those who go to another amputation. It's a very small number of patients. You have to decide which way you have to go, because if you do that negative pressure, you do it for 1 week, let's say, for example, you see the granulation tissue that grows into that wound and it helps. That's a pretty happy end for that patient. But if you see that that therapy doesn't work, it's very clear that you have to go with the surgery a level up. So we have a transmetatarsal resection, and then it's pretty clear that the next level for that is the underknee amputation. So as a surgeon, I have to decide in that critical time, after the first days, after the intervention, which way you have to go. Some of them are lucky, and we do the transmetatarsal resection. So that's a small intervention that we have to do. We completely take out the infection, and then he goes to the vascular surgery, which is very important. So he can revascularize the big vessels, and he has the vascular substrate to recover that wound. The hyperbaric oxygen therapy, the negative pressure wound therapy help, but they help in a very small number of patients. That's what I wanted to tell you. It's pretty clear from the eye of the surgeon if you have to go one level up, or you can stay to the first intervention, or you can direct the patient to the vascular surgery immediately after you perform the surgery, the resection and the elimination of the infection, and that is the next step for the patient.
For the vac machine, let's assume that you do below knee amputation and the stump is still infected. Do you use a vac machine in open wound where you just make a ligation to the popliteal artery, or you think this area is still risky to utilize vac machine where you have an underlying newly closed artery? What do you think?
We don't usually use the vac machine at the below knee amputation. We use that one at the transmetatarsal resection, the lower resection. The below knee amputation is a pretty clear step. Now, if you do that, you can see that the wound will heal pretty fast. If you have any doubts about it, you don't suture the wound immediately after you performed the amputation. You can let it open. You can have great care in the first days after the amputation with special bandages, so you can perform the suture, let's say, about 4 or 5 days later after the amputation was performed. All right, and you have to take care, very, very good care, so that wound won't reinfect. Right, we have the infection was pretty deep, and you don't want to saturate from the first time, so it will collect after the intervention. So that's why you have to leave it open for 4 or 5 days. You can see that the granulation starts. You can see that the infection is over. You have the right antibiotic from the wound culture, and then you perform the suture, but no vac machine there.
Yeah, thank you very much. I think there is a question or maybe a comment from Anna Christina King. After this amputations that we have to come back, we don't suture and we use a vac to cover the wound. I think she means the transmetatarsal.
Yes, probably.
Yeah.
Or in the tibia or mid-femoral amputations also.
I didn't understand what Anna Cristina said.
She's saying the tibia and transmetatarsal amputation.
Okay. Yes,
Yeah,
we
is
use
that
it
what
for
you mean, Anna?
transmetatarsal.
Yes. In these patients that we have to come back because maybe there's an infection or something, we usually do not close the wound and we leave a vac therapy, and that has helped us a lot since it controls the exudate and also it helps us granulate and control the infection.
This is below knee amputation, you mean, or the transmetatarsal?
Yes, below knee amputation and sometimes in the femoral amputations.
No, but the argument between me and Dr. Dan that is it safe enough to use vac machine and the stump of the below knee amputation, where fresh one, of course, where you just like gave the artery 2 or 3 days before. Is that fine? Is it safe enough?
Yes, we use it. We sometimes amputate and immediately put the vac on, and we hadn't had any problems.
Okay, so I assume so. Although personally speaking, I think I would say I must be careful and do some precaution and put in my mind that I will put, let's say, some muscular tissue above the artery just to separate the artery from the suction itself. I would do that during surgery as a precaution in case that I consider that I may use vac machine postoperative in a few days. Do we agree on this, Anna? Is this what you mean exactly, or you have a different option?
Yes, when you do the amputation, you have to make sure that the artery is well closed and that the artery is not in contact with the sponge. But you can use it immediately after the amputation.
I see. Yeah, I agree on this. Yes, I agree.
Absolutely.
Yeah. Mr. Chairman, any question?
No, I have no further question. I know Jeanette Travis is a chairperson too. Do you have any questions? No, it doesn't seem like that. The next speaker on the list is
Thank you. Thank you very much.
Thank you very much,
yeah.
Dr.
No,
Dan.
sorry. Thank you. Of course. Thank you very much.
Thank you.
I'm sorry with that.
Oh, you're there, Jeanette. That's great.
Only.
We'll transfer the host to you, Dr. Janet, in 1 minute, please.
Okay. Can I share screen? Yeah, sure.
Are you the host now?
Beg your pardon?
Are you the
Yes, I'm
host?
the host. If you want me to be the host, I will be the host, yes.
Yeah, you can be the host so that you can share your screen.
Oh, okay. So do I do my presentation now?
Yeah, let me check. Okay, we'll transfer to you in a minute, 1 minute.
Okay.
Okay, you are the host now, Dr. Janet. You can go ahead.
Share screen?
Yes,
Share your
please.
screen.
Okay. Right, now, where are we? Okay.
If you allow me, just Dr. Janet, just to introduce you. I know it's 11 p.m. now in Australia. I'm really sorry that
It's actually 12. It's 11:45.
it is too late. I'm really sorry for that. I couldn't recognize that Australia is that far. I thought it's only 6 hours time, but I'm really sorry. Dr. Dorothy, she is
Quite all right.
from Macquarie, if I'm saying it right, University.
Yes, I'm actually I'm a PhD. I've finished my PhD, and I gained that from Southern Cross University in Lismore. I did my master's at Macquarie University in Sydney. Yes, and I've been working in a pathology lab in microbiology, from which I'm now retired.
Thank you very much. Go ahead.
Okay, so you can hear me now?
Yes, but we need you to share your screen, please.
Yes, well, okay, share screen. I have. Now, what am I going to do? Here we go. Good. Okay, great. Fine. So you can't see me. How do you get to see me? You don't have to see me. You don't want to.
No, no need to see you. The slides are enough.
Hey?
It's okay.
All right. Okay, so I will start.
Yes, go ahead. Thank you.
Okay, all right. So I would say start. Welcome to this presentation, which compares changes in the pre and post microbiome of diabetic foot ulcers using 3 single-session debridement techniques. So chronic diabetic foot ulcers can develop following foot injury, which can result, which we've been through this tonight, but I'll reiterate it, from unprotected bare feet, ill-fitting shoes, or a variety of conditions, including Charcot foot and other foot abnormalities, and can render the feet susceptible to damage. And ulcers are often associated with comorbidities, as we've also heard, including peripheral neuropathy, ischemia, peripheral arterial disease, rendering foot damage painless with bleeding suppressed. And an ulcer can develop in a few days. And ulcer healing can be challenging for both people living with diabetes and clinicians. And amputations are often the outcome. Let's bring this down here a bit. Okay. As ulcers become chronically infected, damage to tissue inhibits healing with the risk of systemic involvement. Amputation is clinically indicated to prevent potential life-threatening infection, and the person with the amputation is severely impacted both physically and emotionally, requiring continual health care, which can also create an added economic burden on the community. Now, this photograph was taken 5 months before this one. You can see that the amputation has healed very well, which is very fortunate for the patient. And they use negative pressure wound therapy with polyhexanide dressings over that period. And he lost his second, third, and fourth digits, and the long-term consequences would be very distressing, to say the least. Okay, now the next one. Can I get there? I think so. I'm just trying to get my, hang on, trying to get it going. All right, go on to this one. Just maybe, can I move? Oh, yes, I can move that over there. Good, great. I'll have to put you in the corner. So the polymicrobial bacterial biofilms in the diabetic ulcers can complicate prolonged treatment. And they're described as matrix enclosed communities of committed planktonic bacteria, often present in these chronic ulcers. Biofilms have developed mechanisms which can protect the biofilm community from antimicrobial attack, including inactivation of antimicrobials, antiseptics, prevention of host immune cell penetration, and persistent cells, all of which can lead to antimicrobial tolerance. And here we have a photo of a very serious looking biofilm on an ulcer. And this greenish, I don't know if you can see it's so greenish, but it's the extracellular matrix which protects these biofilms. And they're a mixture of nucleic acids, polysaccharides, lipids, and proteins. And if I can get to my next slide, I'll go here. And they call this the green slime, and that provides protection for the microbes within this biofilm. And these are the bacterial cells just on the wound. There's the host circulation, and these committed microbial cells, quorum sensing. Yes, there's a lot of steps before they get to this stage, but I won't go into the details. And so we have the host circulation, and then as the biofilm matures, you have oxygen gradients and water channels for nutrient transfer and waste disposal. Very efficient and well set up communities. And biofilms are constantly in a state of flux with continual attachment and attachment of cells. So debridement is used to remove devitalized infected tissue and the associated microbes to expose the cleaner ulcer bed. And it's a common form of treatment. However, another biofilm can form on a clean ulcer bed, as remaining microbes can form new biofilms, and therefore regular antimicrobial treatment, including debridement, is needed. And lower pathogen abundance and higher bacterial diversity in the biofilm are desirable, as high bacterial abundance is associated with poor healing outcomes, and low diversity increases the ability of a pathogen to become dominant in the biofilm, as less organisms compete for resources to survive. So the aim of the study is to compare the pre and post microbiome using 3 debridement methods. And the first being conservative sharp debridement, and it's routinely used by many health professionals, as you'd be aware. And this method utilizes a scalpel blade on a sterile saline cleansed area of the wound, and to remove the necrotic and infected tissue to expose a cleaner ulcer bed. And the ultrasound debridement uses low frequency ultrasound. In this case, it was 25 kilohertz, coupled with a normal saline spray. And just bring this up a bit. Wrong way. There we go. And this wand, you have the ultrasound and the saline spray pulsing through, and you can see how it's sprayed onto the wound and it cleans it up very well. And surgical debridement, which in the process of exposing the ulcer bed can involve amputation of digits if clinically indicated, with the consent of the patient, of course. So the methods, briefly, the pre and post debridement swabs were collected using the Levine technique. Don't know whether any of you are familiar with this, but it's a standardized method of swab collection, which is important for consistency when comparing other studies where swabs have been used to collect the samples. And the swab is rotated over a normal saline cleansed 1 square centimetre area of the ulcer for 5 seconds, but you apply enough pressure to exude and collect wound fluid onto the swab. And this is just a little photo which just shows a swab collecting a sample. It's not particularly meaningful, but I thought I'd put it in there. And it's a very nice clean wound too. Now the microbiome in each pre and post sample is identified using a traditional aerobic and anaerobic culture, and the culture plates were incubated for 7 to 10 days to enhance anaerobic recovery. And also, B, we used DNA sequencing using the 16S ribosomal RNA gene. And we had ethics approval and all participants provided informed consent. So the complete culture data set of bacteria was filtered to include 5 common pathogenic aerobic genera: Staph, Strep, Enterococcus, Chronic, and Pseudomonas, and the Enterobacteriaceae family, which includes such genera as, you know, your E. coli, Proteus, Enterobacter, and also mixed anaerobes. We included mixed anaerobes as one group because we were not terribly good at isolating the individual anaerobes in the culture. And the remaining bacteria in the culture data set, which were not included in this group, were described just as one group of other bacteria. Now, the community profiling and sequence analysis was performed at the University of Queensland in Brisbane, Australia, and the complete sequence data set was filtered to include the same 6 aerobic pathogen genera, as I mentioned before, and as described for the culture data set, and included obligate anaerobic genera, Feingoldea and Anacoccus. The other bacteria were included in the analyses, but were grouped as other bacteria for illustration in the stacked graphs. The statistics, the data was rarefied and filtered to remove samples with very low read numbers, which then provided consistent depth of coverage within each debridement method. And the cutoff read values were for conservative sharp 545 reads, the ultrasound 580, and for the surgical 2,300. The diverse function, I just go through this quickly, was used to generate the genera and species richness and Shannon's diversity based on that rarefied data. Separate analyses using the Wilcoxon signed rank test were undertaken for each debridement method, and to compare pre and post mean sample values for the abundance, number of reads, species richness, diversity, and the abundance of each pathogen group. And a 1-factor Permanova was undertaken for each debridement method to compare pre and post community composition, which also provided a visual representation of pre and post communities using the principal coordinate ordination graphs across the 3 methods. This next slide shows, as I will say up here, the species richness for both the culture and the 16S RNA gene sequencing. And you'll see that the culture does not isolate very many organisms. These are mean values, whereas the sequencing does identify a lot more organisms. So, and you can see also that the means are increasing in the richness using the sequencing, but in the culture, because of so few numbers, they seem to be going down. But anyhow, I'll show you a little bit more of this in my next slides. So the message from this is that you get much fewer organisms identified or isolated from culture relative to what you identify from sequencing. And here we have the whiskers, box and whiskers graphs, with which I suppose most of you would be familiar, but I'll quickly run through it. And this, the box and whiskers, gives you the range of the sample values, so that the blue is the pre-debrided samples, the red is the post-debrided samples, and the bottom whisker is the lowest sample value, and the top is the highest. This is the range within the box, 50% of the range, and the median. And the post-conservative sharp debridements showed a significant increase in richness post-debridement. Now, the other two methods did not show a significant result, but you can see they have increased, and also the ISD has increased. So we're getting a change. We're getting a change in response to just this one single session debridement. And so I'll now go on to the abundance, the mean abundance. We estimated the mean abundance by looking at the copies of the 16S RNA gene using PCR. And here we see again, we have an increase, a decrease in the abundance, a significant decrease using the conservative sharp, and there is a decrease also using the ultrasound and also the surgical debridement. I forgot to mention too that now our numbers are no longer 7 per method. We had to reduce to 6 for the ultrasound and 5 to the intraoperative surgical, because there was one sample where the read number was below the cutoff point, and 2 samples where the read number was below the cutoff point. Interesting here is that the range of the samples that were going to be surgically debrided is much higher than the range of the samples for the other 2 methods. And I would say, as you would probably agree or not with this, that the reason for the surgical, or choosing these samples to be surgically debrided, is possibly because of the increased bacterial burden on these samples, and that's quite well demonstrated in those graphs. And Shannon's diversity, and as I mentioned before, diversity is very important in these wounds, because if they do have organisms in them, we don't want them to have dominant organisms with very few organisms around. If you have a high diversity, it means you've got a lot of competition for these organisms to gain a foothold and become dominant. So with the Shannon's diversity in the conservative sharp, we had an increase, a significant increase, and also in the ultrasound, a significant increase. For the surgically debrided, we didn't have an increase, but you can see the range is still very high. So for the diversity index, and they were a very, to start with, they were a very diverse group of wounds as far as the pathogens were concerned. So now we'll have a look at the culture, and these are the stack graphs, and you'll see that, I'll go back here again, that we have here we go. Yeah, we have the each organism, Pseudomonas, each color represents one organism, and we can see in Enterobacteriaceae, which is the black one in this particular graph, has been eradicated in the post-debridement. And here, along here, we have the pre and post, the samples, pre and post, pre and post. So not a lot of organisms, but interesting that some of them were eradicated. This one here, you've got eradication of the other bacteria that were in the sample. And you have a change here from other bacteria to staph, and we've got staph in the pre. And Enterobacteriaceae and Enterococcus didn't change. So we're getting some change in the samples. The ultrasound, we have 4 different organisms here. Enterobacteriaceae, two types of Enterobacteriaceae, 2 species. We also have the Enterococcus and staph. And in the post sample, that's been reduced down to other bacteria and strep. So we don't have these at all in the post sample. And in the we have some more strips post. This is found in the post only. And where we have, which I neglected to mention, where we have no polymers, it means that there is no growth. And we have in this one, we had nothing in the pre and something in the post, and the same here. So both had good stuff in the post. And for the surgical debridement, we have a fair amount of a change in that we've got, we've lost our Enterobacteriaceae, and we've eradicated those two organisms as a result of the debridement. There's nothing growing in the post. In this one, we've got the Corynebacterium staph, and we've lost the Corynebacterium. This one, we've lost the staph. We've gained something here, but and the next one, we've lost the Staphylococcus, and here we've lost the Corynebacterium. And this one here, we actually have mixed anaerobes. We have isolated some mixed anaerobes in this particular sample, but they were eradicated, and we're just left with another staph here. So yes, the culture was interesting, and it does definitely show us something. And the majority of the laboratories use culture. There's not too many of them use the sequencing because it's far too expensive, and it's fairly labor intensive to prepare the samples. But we'll have a look at the relative abundance of the sequence samples. And we have the conservative sharp debridement. In these samples, we have very little difference. We've got Pseudomonas, Enterobacteriaceae, Streptococcus. Now, we had no Streptococcus found in the culture for the CSD samples, so that is interesting. But we've picked it up in the sequencing, and we also have had a bit of a change here. We've reduced our Enterobacteriaceae, we've reduced our Enterococcus, and here the Streptococcus is popping up here. We've got post only here. We've got another post only Streptococcus here, and I'm pointing this out because there's, I'll get to that later. But the majority of organisms are staphs, as you see from this blue, this one. And so, and Pseudomonas in the conservative sharp. Now, in the ultrasound, we have a lot of Streptococcus, pre and post. In this one, we have increased quite a much higher relative abundance of pathogens. We have a very small relative abundance in the pre, but we have quite an increase in the post of the Enterococcus, and the same with the staph. And here we've got just straight strep, apart from a very, very small relative abundance of staph in the pre, then that has disappeared in the post. And this one, we have reduced quite a lot. We've got rid of the bacterium and most of the Pseudomonas, and we just have a little bit of staph. So we'll look at the surgical debridement, which is probably what you're interested in. And we see we have a lot of anaerobes in surgical debridement. I'll just show you them. So the Feingoldea anacoccus. And so we have increased here, we've increased our Enterobacteriaceae. We've decreased the anacoccus there, or Feingoldea. And these remain fairly consistent. But again, we've got some changes, and that's the important thing to be looking at. So I will go to the next slide, which is it shows it's a really, I like this slide because it does say quite a lot about the actual presentation of how these means and standard deviation, mainly the means we're looking at, of these pathogens have decreased or increased as a result of the debridement. So you've got Staphylococcus here, that's decreased somewhat after conservative shock. It's decreased a lot after the ultrasound, and it's decreased quite significantly, say about, maybe 15% after the surgical debridement. And the other, we have most of them decreasing. Some of these smaller ones are very hard to discern, but the main message is there has been an overall decrease in the relative abundance, in the pathogen relative abundances post debridement. And why I was talking about the Streptococcus being found in a lot of the post debridement samples is that if you look at these, you can see that the Streptococcus is marginally higher post, and this one marginally higher post. And in the surgical debridement, well, yes, marginally, very marginally higher. But the point I'm making is that Streptococcus may lie deeper in the wound and be partially protected from debridement process, as evidenced during the present study, with the percentage of Streptococcus being identified in the post samples only. And we could look at perhaps confocal laser scanning microscopy to investigate transverse sections, and that may be useful to confirm or otherwise that Streptococcus does lie deeper in the wound, and I'm sure some of the other pathogens do also. And with the surgical debridement, you would get a lot more exposure too, and that's probably why we got a lot more anaerobes in the surgical samples, because especially post, because of the depth to which the debridement went. So now we go to the multivariate, I should say, look at these communities, and the permutational analysis of variance results confirmed there were no significant differences between the pre and post debridement community. So they didn't really change that much according to the multivariate analysis. And there were more differences between the wounds than between the pre and post samples overall. However, we do have some samples that are still very similar, and say number 12, that's clustered quite closely, which would indicate there's not a lot of difference in the communities pre and post, with the pre and post blue and the post red. Number 8, it's a bit jumbled there, but it is number 8. And number 14, very, very closely clustered there, and 20, and number 29. So we'll have a look at the relative abundance graph again and see just how closely they do resemble each other. So number 8, well, they're almost the same. So therefore, yes, they clustered very closely. So no difference in the between the pre and post. And number 12, strep and staph. We have the other bacteria, which could, you know, mean quite a lot of bacteria within that group. And that's something I didn't mention earlier, was that with the culture, I think we had an average of 13 isolates as against well over 100 identified organisms with the sequencing. So it really does, you know, gives a lot more information, but there are also catches to that too. So, and also now what do we look at? Number 14, and that's all strep. So that's going to cluster because there's not much difference in that. And number 20, we've got strep there, strep slightly higher relative abundance. But these other bacteria are probably very similar because it did cluster as closely as it did. And number 29, and the types of bacteria are very, well, they're the same, except the Enterobacteriaceae have increased somewhat. The Corynebacterium have decreased. We've got staph, strep, but you can understand why those two would have, the pre and post would have clustered. And the other ones, they haven't clustered closely. But as we said, there's probably more difference between the actual wounds than between the pre and post. However, interesting results. So the conclusions, we could say that there is evidence that changes have occurred in the diabetic foot ulcer microbiome across the 3 debridement methods. And a point is that previous reviews on the efficacy of debridement have focused on healing times and reductions in wound size. The change in wound bacterial burden post-debridement has not been well studied, and wound bacterial burden can be a major contributor to non-healing, as you would understand. And bacterial abundance was reduced significantly following a single session conservative sharp debridement, which supports the efficacy of this routinely used debridement method. However, overall, one single session debridement across the 3 methods did not remove the majority of bacteria, which we weren't really expecting, but we did get changes in the diversity, in the abundance, and in the richness. And a significantly higher diversity was found in post-single session conservative sharp and ultrasound. And the increased diversity indicates a destabilized pathogen-dominated microbiome. And increasing diversity post-debridement reduces the likelihood, as I mentioned before, of pathogens dominating the ulcer as more organisms compete for limited resources. And antimicrobial therapy. Single session debridement can provide a window of opportunity for antimicrobial therapy, and there's been a couple of papers written on that. And when the wound is in an acute state due to debridement mediated destabilization and a cleaner ulcer bed, previous studies have suggested that the wound is more susceptible to antimicrobial therapy for a few hours post debridement. And that has been done, I think, in vitro and also, I think, in vivo. Most common pathogens were identified by culture, especially when the pathogens identified using sequencing were in high relative abundance. And 16S sequencing provided greater depth of information on polymicrobial communities. But a point to consider is that non-viable DNA can be included in the sequencing results, can be identified, and therefore it would not be isolated from that sample using culture. So overall, this study has indicated a potential disruption of ulcer biofilm using regularly employed debridement methods. But further longitudinal studies on wounds treated using serial debridement or studies on a lot more samples than I had would be extremely worthwhile. And I just thank you for listening, and I hope you did get something out of this presentation. Okay. Have I finished? Yes, I have. So I will end it.
Thank you very much, Janet. It's really an impressive lecture. Mr. Chairman?
Yes, thank you. I'm glad you enjoyed it.
Yes, Dr. Gustav, any question, Mr. Chairman?
No, thank you. I don't have any questions on that, but I would be happy to hear if the audience have any questions.
I have a question to Janet. First of all, thank you very much, Janet. It's really impressive.
You're welcome.
Thank you very much. And this article, actually, as you know, we are surgeons. We rely too much on the tissue biopsy, and especially if there are negative microbes. So, what do you think? Is there any what you can say that agreement that our way is acceptable, or is there, as you say, that sampling technique could give same results? So what do you think? What is your advice for the surgeons?
I would say, well, for the surgeons, I mean, look, it's invasive. Tissue biopsies are invasive, and that's the main problem. And if you're wanting to do serial analysis, looking at wounds over a period of time, and your people are having patients are having biopsies taken, they're not so happy about that, because it is uncomfortable for them. So the swabs are they're not invasive, and you can do your serial analyses on them. Like you can take a few swabs from, especially outpatients. I'm talking more about outpatients, but they're quite happy to come and have their wound swab, because there's no discomfort. And the swabs, I think I have published a paper comparing tissue biopsies and swabs, and the conclusion was that swabs are quite adequate. Maybe they may not go as deeper as some of the tissue biopsies, because I think you go up to quite a 10 millimeters sometimes into the wound with the tissue biopsies. So you might be getting more of the organisms deeper in the wound, but it didn't seem to make a big difference to the study that was undertaken, that the paper was written about. So I would say, if you can take a swab, because I think it does give you a lot of information, and it doesn't impact so much on the patient. But tissue biopsies, I know they're the gold standard, and by all means, as a surgeon, if you need to take tissue biopsies, you take them, because you'll be doing it intraoperatively, and it won't bother the patient at all, because they'll be having an anesthetic. So that's my answer to that.
Okay, from other aspects, yeah, it's fine, absolutely. The message here that, as you know, we see a lot of patients, either, as you said, in the clinic or in the OR. So we have to understand in each stage what is the best method of sampling or taking a biopsy. But
No.
let's go around and say that, as you know, sometimes during surgery or sometimes in the clinic, once you squeeze the wound, there is pus coming.
Yes, yes.
Do you
Well,
think sampling of pus, do you think does it have any value? We know that it's dead tissue, dead bacteria, dead, etc. But does it have any clinical significance to adjust antibiotics?
look, it can tell you what's, especially if you do serial sampling, because you can see how it's going. And I think that talk last night about the effect of the antibiotics on the organisms that were growing, the organisms decreased, but we had new organisms growing in response to the antibiotic, because it was the non-dominant organisms which were just lying there were able to get a toehold, because the dominant ones were being knocked out by the antibiotic. So I think it's very, as you're saying, yes, pus. I mean, with this technique, the idea is to just push down into the wound and get enough exudate and fluid to give you a good sample of the wound. And it is standardized. And I think that's very important for if you're going to be doing like research. So I'm probably looking at it from a research point of view, but I'm also looking at it from an effective way of getting samples. And I think the pus, yes, that's important, but it's more important probably to get down into the fluid. And I think that, I mean, the ones that you see are probably very, very pussy, and some of the ones that were sampled when I was up at the Gold Coast University Hospital, they were pussy too. But you do sort of rinse it off first with a saline, sterile saline, and look, I think I would go, yes, they are it's a good way of collecting a specimen. And pus is useful because in the pus there's usually a lot of organisms too. So from a microbiological point of view, yes. So yes, so that's my answer. So what do you think, Dr.
From practice, as you say, that sampling is quite significant and important in adjusting the antibiotics.
Yeah.
We know that it's polymicrobial. At the same time, we know there are a growing resistance to the strong antibiotics.
Definitely, yes.
Yeah, and so we have to, I think you're sampling to adjust the antibiotic and to minimize the chances of exposure of antibiotics to unnecessary either period of antibiotics coverage, like 6 weeks or 3 weeks or whatever, or at the same time adjusting the antibiotic according to culture, as you said. I think there is a place to discuss and to negotiate what is the best option. I think rules are changing nowadays. It's not.
They are, yes. We're having quite they're restricting the use of antibiotics in Australian medical system because we're getting this resistance pattern. And so what they're doing is they're monitoring very closely the prescribing of antibiotics and looking at maybe doing other things like, debridement regularly, and trying to keep on top of the wound before it gets to the stages where you see them where they're just, they're very, very badly infected, and you can have systemic involvement, and the patient's life can be at risk. So I feel that they're trying to keep away from using too many antibiotics, definitely, and trying to use other ways of cleaning up that wound and keeping it keeping the patient safe as well.
I know that I know that from your study you did, RNA study, but do you think can we have the same result by doing just simple culture sensitivity as regularly we do?
Look, the advantage of culture is that you get your sensitivity pretty well straight away. Whereas with the sequencing, you would have to be doing whole genome sequencing to get your sensitivities. So the genetic sequencing is probably going to go, we're probably going to go that way in the future, but at the moment it's far too expensive. And there are some dedicated laboratories, I think, over in Scandinavia who do actually use the sequencing, and they are a sequencing laboratory. So all their samples do get sequenced. And they do whole genome sequencing. But I think culture is, I'm not saying anything against culture at all, because you do get your sensitivities. However, if you do perhaps have organisms which are not, see, you can only grow the organisms which will grow under the conditions that you have for them. There are some very fastidious organisms that will not grow, and they can be present in the wound, but you can't grow them because you haven't got the proper conditions for them to grow. So you staph, your streps, and or your E. coli's and all those, they'll grow quite happily in the lab. They're great, but it's the uncommon ones which cause the problem. And this is where the sequencing can come into it, in that you can do your culture and you think, oh gosh, we're not getting much of a response from this. Where what's going on? It's still infected, and we're treating them, as best we can with the basic antibiotics. Nothing's happening. You could use sequencing then to see if there's something there that you cannot pick up on culture, and that's where you can use the two. You could use the two systems, but again, it is very expensive. But sequencing is becoming a lot more inexpensive as it's becoming more common to use. So in years to come, it will sort of the cost won't be quite so prohibitive. So there you go. I mean, stick to your culture, definitely. I mean, the laboratory where I work, we were just doing culture.
No, but let's go other way around. Expensive is something relative. Do you think that saving the unnecessary antibiotic use, or saving the yearly resistant, in case of getting resistant 5 years, you will have it in 15 or 20 years, saving lives that are exposed, do you think those issues can justify utilizing such an expensive, between quote unquote relative expensive technology? What do you think?
Well, I'm hoping that it's good. The price of it is going to come down, because, and it has reduced somewhat just in the time I've been involved with it. Look, it's a hard one, because as I said, there are some laboratories overseas, not as far as I know, not in Australia, which are definitely just all sequencing. That's it. That's all they do. And they do whole genome sequencing, which then gives you the whole picture of the organism, because you've got the section of the organism which will tell you the resistance pattern, and therefore you've got an idea of what sort of, if you do need to use antibiotics, which antibiotics are going to be appropriate. Say if they had, a beta-lactamase, section in their DNA. I mean, I think it's going to come in the future, but at the moment, I think we're going to be with culture, because it's the other way is prohibitive, and the training and the reading, though that's becoming much easier too, the actual reading of the DNA sequencing, because that I sent that to a dedicated lab, like to the University of Queensland, for the actual sequencing and the identification. But some laboratories, the ones that do have the setup for the DNA sequencing, have their own machines for reading it. So it's sort of all contained within the laboratory, which makes it a lot cheaper. So, but, you know, I would not promote using DNA sequencing at this stage, because it just would be too cost, you know, prohibitive. But then, as you're saying, if it means, you know, saving lives and getting the correct treatment earlier on, well, yes, it's the way to go. But yes, it's sort of, there's pros and cons.
Thank you very much.
Hasn't helped you. That hasn't helped you at all, has it?
Thank you very much.
Okay, then. All right. Thank you. Thank you very much for inviting me. And it's been a very, what can I say, learning experience for me. And I've enjoyed it very much.
Thank you.
Thank you.
Thank you.
So, are there any more questions from the audience to the speakers, or comments on anything else related to this? No, it doesn't seem so. Then I think we could close the session.
Okay.
Yeah, I think we will close the session. We will meet tomorrow, same time, 2 p.m. So thank you, Dr. Gustav, for sharing this session. Thank you, Dr. Janet. And thank you, Dr. Dan. It is really a pleasure having you today. We meet from Australia to Romania to Sweden to Saudi Arabia.
Rather amazing. It's amazing,
Yeah.
isn't it?
Yeah.
Yes. Thank you very much.
Thank you. Pleasure.
Thank you.
Yeah.
Thank you very much.
Okay, then.
So yeah, bye-bye.
Bye.
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 Bye. Bye.